The topic of this presentation is rheumatoid arthritis, and this is Joy Hodson. And we're going to talk about rheumatoid arthritis, often called RA. And what is it? It's a chronic, progressive, and it is also systemic inflammatory process that affects primarily your synovial joints. It's the synovial joints, but again we say it's systemic. Remember in the earlier presentation we talked about the fact that connective tissue is throughout your body, and that is what is getting inflamed and damaged. And you usually see periods of remission and exacerbation, which means people have periods where they really seem to have a decrease in function and more pain, and then periods of time when they seem much better. The length of time people have for these is highly variable, but some people have long periods of remission and just very short periods of exacerbation. Some people have very long periods of exacerbation and not great remission periods. It is considered one of the most destructive connective tissue disease disorders, and it is the most second common connective tissue disorder in adults, being prevalent in about 1% of the population. The incidence and the onset, it can occur at any age, but usually tends to peak of the person between 30 and 50 years of age, and it tends to involve women more than men. The etiology, we really don't know, but believe it's a combo of the autoimmune system and a response with some genetically susceptible person who may become exposed to some sort of antigen that really has not been identified. What they do see, though, is that there are autoantibodies that are the rheumatoid factor, and that combines with IgG to form an immune complex that deposits on those synovial membranes or cartilage, and that leads to formation of complement, and that leads to your inflammatory response throughout all this connective tissue. One of the unique subsets of rheumatoid arthritis is juvenile rheumatoid arthritis. The majority of people who have juvenile rheumatoid arthritis can be put into remission. However, that is not all of them. The onset is between the ages of 2 and 5 or between the ages of 9 and 12. And there are 3 specific types or categories of juvenile rheumatoid arthritis. Basically, the first one, periarticular, is looking at the fact of how many joints are involved. And they're saying it's basically 4 or fewer joints being involved. The last one listed there, polyarticular onset, the 25%, is looking at 5 or more joints being involved. Whereas being systemic in onset is not really focusing on the joints, but the systemic effects. And that's about 30% of them, and that they tend to have daily temperature spikes, usually in the afternoon, for about 2 weeks, and they may have a macular-papular rash. There does not tend to be any significant difference among geographical locations, and if they cannot be put into remission, they do tend to have significant joint problems. They usually tend to be symmetrical and have a lot of stiffness, decreased mobility, and fatigue, and joint pain. As far as the pathogenesis, which occurs juvenile and with the adult, locally there is inflammation. Basically, it's synoviitis of the membrane there. And what happens with that is it gets very irritated and enlarged, and then you end up with proliferation. And that is what differentiates differentiates your rheumatoid arthritis from other different types of arthritis. The inflammation, though, can cause a lot of pain. In the joint, it causes the warmth and the swelling. When we have the proliferation of the joint, there's 4 different stages that can go through. And basically, the proliferative stage, you get lots of masses of the lymphocytes and monocytes in there. And they almost act like a neoplasm. The pannus formation is a vascular granulation in a lot of those inflammatory cells, and it does tend to erode that articular cartilage. And that does not have a blood supply, so it can't regenerate. So usually that will then erode down to the bone. This pannus then gets more formed and becomes more fibrous because granulation tissue tends to build in there, and it gets tough, and you get more scar tissue, and that's what's going to inhibit some of the joint movement. This will then progress to bony ankylosis because that granulation tissue then gets calcified, and that leads almost to a bony union. So you can see that people then have very limited movement in these joints. The systemic effects that we're looking at, again, all the bodies, not just all parts of the body, not just the synovial joints can be affected. So examples would be a vasculitis because the lining of the blood vessels can be involved. Or you may have malfunction or failure of any organ because of the connective tissue involved. And again, it can affect the eye, the nervous system, and the skin. Symptoms and signs of RA. It is a chronic symmetric polyarthritis, meaning it's going to be symmetrical. If it involves one elbow, it'll involve the other elbow, right and left. Both hands, right and left. The symptoms do tend to be very variable, again, exacerbations and remissions, but it is chronic. It is reported that about 15 to 20% of the patients have mild disease with intermittent flares. They tend to have a good prognosis. But the other, 80% or so, which are the majority, have progressive joint disease and damage, and that tends to lead to decrease in function and other comorbidities. The onset can be slow, but it also can be very acute and severe. And it is a chronic disease, variable courses. One of the significant things for people to be aware of is that infections, injuries, or operations can a lot of times precipitate a flare. And also looking at stress and emotional upset can also affect the development of a flare-up. Other things that people complain about is fatigue. 52% they're too tired to work. Up for more than 4 hours without taking a rest. With juvenile rheumatoid arthritis, that course is also highly variable, but most of the time, if they're not in remission, they can 30 to 40% can 10 years have some substantial disability, and again, worse with chronic polyarticular disease. Early manifestations of RA, and we look at it and you can see the picture there of what those hands look like, and those joint signs and symptoms. If you've ever met anybody who's had some of the initial RA, what they'll first complain about is their hands and their classic signs. A lot of times it's, again, bilateral, so it would be both wrists, both feet, and the number of joints increases as the disease progresses. They will complain about pain in their joints. They will have swelling, warmth and erythema, and a lot of stiffness. And as you can see here, in the middle, the middle knuckles, interphalangeal joints, those are the ones that are swollen. They're called proximal interphalangeal swelling, and that is very typical of somebody who has RA. They will especially have a lot of tenderness on palpation too. So one of the things they may do is just squeeze somebody's hand, and if they have pain, that may lead to someone to consider, are they developing RA? If they become tender, if they aspirate anything from the synovial fluid, it usually tends to be have high WBCs if they have RA. Most of the time you don't have any WBCs in your synovial fluid. Other systemic manifestations, weight loss, fever, extreme fatigue that we talked about. 52% claim that they cannot work for more than 4 hours without taking a rest. Anorexia, weakness. They may have some paresthesias. And then in juvenile RA, growth may be retarded. Late manifestations of rheumatoid arthritis in the joint stages are very unique. And if you've ever seen anybody with advanced RA, you look at the picture on those hands and you can really see those. You've seen people with these hands that are just curled up and you have that ulnar deviation. So they have, again, the stiffness, the edema, and the muscle atrophy. So they tend to lose function of that joint. They may also have what they call rheumatoid nodules or subcutaneous nodules. They're usually painless, and they can be around for a couple of weeks or a month, and they're usually over a bony prominence. They're just kind of round and movable. And they tend to be associated with some of the rapidly progressive and destructive disease. And the muscles get atrophied. If you have stiff joints, you're not moving them, so those muscles get atrophied around the area. Joint deformity. Boutonnieres, which you can see on here, where that middle joint is up, okay? Makes that joint very difficult to move. You can see also here a swan neck deformity on that right hand picture, where the finger just goes into the look of a swan neck and the swoop of that. The fingers also just look like they're spindle-like because of the swelling of the proximal joints, that the ends of the fingers look so much thinner. And the classic ulnar deviation, where that hand is rotated laterally. So you can see that they're moving. So it makes that whole joint easier, more difficult, I should say, to move. Late manifestations that are systemic. Again, it affects all the organs, which can become ischemic and malfunction. So you may see things like pericarditis, fibrotic lung disease, osteoporosis, anemia, or Sjogren's syndrome, which is a wonderful name, isn't it? Which is a triad. Of course, we have these wonderful triads of dry eyes, dry mouth, and a dry vagina. You also may see uveitis, which is very much more unique to juvenile rheumatoid arthritis. But what happens with that is they have eye pain, photophobia, redness, and blurred vision because of inflammation of the iris and the ciliary body in the eye. So what you're seeing there, they need to see an ophthalmologist every 3 months to follow up with that. As far as the systemic complications, the rapid report that came out claims that people who have RA tend to have cardiovascular disease 10 years earlier than people who don't. They have an increase in pulmonary disease, and twice the diagnostics are basically based, is a clinical diagnosis. It's looking at your signs and symptoms, looking at the arthritis, the degree of inflammation that they have. And also that pannus, you can almost feel it as a thick rubbery mass around that joint, and that helps confirm the diagnosis. There are a couple labs that are out there. The rheumatoid factor, it's certain antibodies that are made in large quantities in that rheumatoid synovial membrane. It is only present in about 80% of the patients with RA. And alone, it is not diagnostic because other disease processes and inflammatory conditions can elevate a person with RF. And again, not everybody with RA is going to have an elevated rheumatoid factor. So it helps confirm the clinical diagnosis of the signs and symptoms, but it alone is not a diagnosis. And it also is not really useful to follow it as a titer. It does not seem to, not everybody's positive, and it doesn't seem to be that unique. What can be helpful for looking at the degrees of inflammation and what's going on with the patient as far as an exacerbation may be the ESR or the ANA. Again, neither of these are specific to looking at the rheumatoid arthritis, but they are related to degrees of inflammation. There is also another test out, the ACPA, which is an anti-citrullinid protein antibody, which is much more specific than the RF, and so it may lead to an earlier diagnosis, and it can be predictive of the progress somebody has. They may look at serum complement, which would be decreased because it's being, and then your immunoglobulins are typically elevated, especially the IgG, because it's needed to combine with that rheumatoid factor. X-rays, you're going to see those joint deformities, and with an arthrocentesis, again, usually that synovial fluid is sterile and opaque, but with an RA, it's almost always abnormal. It's kind of cloudy and milky and has a lot of inflammatory cells in it with leukocytes. Goals of treatment in RA is to preserve your joint function, prevent deformities, and relieve the symptoms that people have. Medications are one of those ways, and what they're calling the medications for rheumatoid arthritis are DMARDs, disease-modifying anti-rheumatic drugs. These are non-biological and biological medications. These drugs work by modifying the disease, not the symptoms. So you're not really seeing the step-by-step approach that we used to have. We used to try people with treating the symptoms, with looking at the NSAIDs, using aspirin, using corticosteroids. And again, that is only doing, what that's doing is treating the symptoms, not preventing the disease process. Because people can get significant joint damage within 2 years. So they are now, the move is to start on these DMARDs as early as possible. Because they have, people were first concerned about the side effects of the DMARDs, but they've really found that the side effects are no worse than using some of the salicylates, NSAIDs, and corticosteroids. So people are starting to take these drugs as soon as they're diagnosed, and they're not waiting until they have failed multiple courses of NSAIDs. Now, they may have to take some of the non-biological drugs and see if they work first before they can start the biological medications, simply because of expense and getting approval for such treatment. But the hoping starting these people earlier on these meds are going to decrease their disability over the long term. And the contention is that, again, these drugs are no more toxic than high doses of NSAIDs, and they're better tolerated long term than corticosteroids. So with you, again, your meds may be non-biologic or biologic. The non-biologics that you may be seeing used are the methotrexate, which is the most popular. It tends to work very quickly, so it tends to reduce the symptoms. One thing you have to be careful about is that somebody does not have hepatitis, and they need to be careful about how much alcohol they drink. And it's usually the first drug that is tried out there. Azulfidine is sometimes used with mild to moderate disease, but what you will see, you have to be very careful with that, is that they do not have an allergy to sulfa or aspirin. The other one is Plaquenil that you may see. It's an anti-malarial. People need to get eye checks if they're taking Plaquenil, but it seems to have some good effects for what people are looking at. The new DMARDs, or biological response modifiers, some of them you've probably heard, and they've been advertised out there. You've got anti-tumor necrosis factors, the Enbrels and the Remicades. Both of those, what are they doing? They're interacting with the tumor necrosis cell surface membranes, and so they decrease the inflammatory and immune responses. The problem is when you're decreasing the immune response, what are you creating for a person? You're recreating the person's risk of really being able to mount an immune reaction to an infection. So therefore, with any of these, you have to be very careful about any infections. They need to watch for them carefully and get treated very quickly because they can become a sepsis. And also looking at screening them out for TB. If they do have TB and they take these meds, they can get a severe form of reactionary tuberculosis that gets reactivated. Also, they need to be careful about taking any live vaccines and get that cleared by their physician. And here you have some of the names of some of those anti-tumor factor meds. There is also some meds out there, again, that block the action of interleukin. So again, decrease the inflammatory response. So with these, the Ankara or the Actimara, you have to be very careful in checking renal and hepatic functions and being careful with infections. Occasionally, the anti-proliferative leufonamide may be seen, but it's extremely expensive. It stays in the body for up to 11 years. I shouldn't say 11 years. Stays up the body for 2 years, and unless they go through an elimination procedure with cholecystramine, for about 11 days. So nobody under the age of 18, and not if you're pregnant. Other ones are your T-cell activation inhibitors, Oracel, and B-cell depleting agents, Rituxan. Other medications that we're talking about, you may see salicylates and NSAIDs used, again, as a bridge if somebody's trying on a new med to help them feel a little better. But again, it only treats the symptoms, not the disease. Again, with any of these, you have to be very careful about any GI upset and bleeding. That is one of the major complications of these, especially at the doses that people take them at and the chronicity. One of the COX-2 inhibitors were designed to help decrease that risk by having the COX-2 inhibitor. However, they're also related to increasing cardiac risk. So there's very few of them on the market, and people do use them when the risk outweighs the other risk of cardiac disease. But you do have to be careful in taking them. Corticosteroids, again, you don't see them used very often, maybe just for a bridge for the pain until the other meds start working. If there's an injection, they can last for weeks or months for helping with the pain. Additional treatments and modalities, big thing is pain management. Think about all the things you've learned about pain and what we can do. The use of TENS may be helpful, imagery, alternative methods, and also realizing that being pain-free is probably not realistic. It's having pain that's manageable. Using, supporting and maintaining the joint function. Having PT and OT. Having splints. Keeping those joints. A lot of times people will wear splints at night in order to keep those joints in a functional position. That ulnar deviation can really cause some havoc with how a hand is used. So if they wear a splint at night, to keep it in alignment, it can help prevent problems. Assistive devices, things like a spoon to help one feed themselves. If their hands are stiff, they may not be able to grab the tableware easily. Having a plate with the scoop end on it, so they're not, when they're trying to get their food up, it's not going all over the place. And joint can be very helpful. Joint protection plays a role too. Exercising in a pool allows that freedom of movement, and again, minimal gravitational pull, so that when they're inflamed, heavy resistance can really aggravate the pain. So they can keep some of that range of motion even after that, even then, while they're in that state. But passive range of motion can be helpful, but they should not be doing a lot of heavy resistance. Pool works good because it decreases the resistance. Rest and positioning, ice and heat, all important in that pain management. One of the key issues Use ice on hot joints. If they're acutely inflamed, ice usually helps the most until that inflammation decreases. Once the inflammation decreases, they can move on to using some warmth. If they're really stiff, sometimes the shower and hot packs can help. Again, if those joints are not acutely inflamed, heat tends to be more beneficial with juvenile rheumatoid arthritis. And posture is important, keeping that alignment. Firm mattresses, just a small pillow so they don't get contractures in their neck, and sometimes encouraging that prone position to keep all the function that they can have, and flexibility. Fatigue, why that happens, we're not really sure, but we need to teach them to balance this and pace their activities and having rest periods, setting their priorities. Body image plays a role, self-esteem. When you have all those hands and you can't do things that you usually can do, it can become very frustrating. And we need to help people give those